Dr. Linda Flynn is a professor at the University of Colorado College of Nursing. Early in her career, she completed an NIH-funded postdoctoral research fellowship at the University of Pennsylvania Center for Health Outcomes and Policy Research. That is a mouthful. Under the direction of Dr. Linda Aiken. Now, the nurses in the room, do you remember who Dr. Linda Aiken is? She did all of the research on nursing ratios. Okay, not all, but she did a lot of research on nursing ratios. And Dr. Flynn had the privilege of working with her. So over the ensuing years, her funded research has investigated the effects of nursing systems, including nurse staffing levels, the practice environment, the nurse manager leadership on patient care and patient outcomes across the practice settings. Her findings have been published in multiple research journals. Partnering with Dr. Charlotte Thomas-Hawkins, she was among the first researcher to study the impact of nurse staffing levels on patient outcomes in outpatient dialysis centers. Their findings were instrumental in changing federal requirements. She and Dr. Hawkins currently conducting a funded study investigating the effects of RN staffing levels and other systems factors on nurse-sensitive dialysis patient outcomes in 2 states. Dr. Charlotte Thomas-Hawkins is a tenured associate professor and director of the Center for Healthcare Quality in the School of Nursing at Rutgers University in Newark, New Jersey. Her current funded program of research focuses on the effects of nursing systems, for example, nurse staffing levels, workload, practice environment support, on nursing care processes and quality outcomes in outpatient dialysis settings. She was the first researcher to quantify work environment support for nursing practice in the United States dialysis units. In addition, she was one of the first researchers to examine the relationship among nursing structures, RN to patient ratios, and workload. Work environment support, missed nursing care, and patient outcomes in outpatient dialysis units in the U.S. That work helped to lead to policy changes in the Centers for Medicare and Medicaid Services, CMS. Staffing regulations in the CMS dialysis provider conditions for coverage. Her current research is focused on the examination of variations in the facility level, staff nurse, nurse manager, and advanced practice nurse structures, care processes, and work environment support on variations in value-based patient outcomes, patient safety, adverse effects, and nurse outcomes in dialysis units. I'd like you all to please join in welcoming Drs. Flynn and Thomas-Hawkins.
Thank you so much. I'm Linda Flynn, by the way. So, nurse staffing, workload, and the dialysis work environment, does it really matter? Yeah. Well, we're here today to present the evidence, and then you can draw your own conclusions. So I'm going to start out by doing an overview of the evidence on nurse staffing, missed nursing care, the work environment, and patient outcomes in diverse settings, such as acute care hospitals, nursing homes, and Medicare certified home health. And then we're going to transition to the dialysis setting. And Dr. Thomas-Hawkins is going to present our work, the evidence on the impact of work environment, staffing, etc., on patient outcomes, specifically in chronic dialysis outpatient settings. And then we'll wrap up by talking generally about some policy implications and conclusions. So, our job here is to present you with the evidence, particularly bodies of evidence. And then you can decipher and decide for yourself how you want to leverage that evidence. But I particularly love this little cartoon. And here it is, 2 people, and they're saying, want to run from the truth together? And the truth is, we have had research on the relationship between RN staffing levels and patient outcomes in hospitals, for example, for decades and decades. In fact, the very first nurse staffing study was conducted by Florence Nightingale. That's how long we have quantified and looked at the impact of nursing on patients. But that evidence has not always been well received over the decades and over the years. And so in essence, we have run from that body of evidence, or as this cartoon says, run from the truth together for a very long time. And it wasn't until the turn of the century, early 2000s, that we began as a society and as a profession, we began to take this evidence seriously. And I'll just share with you a little personal story. My husband had surgery 3 weeks ago. And he was in the hospital, and I asked the nurses, the RNs, the question that I always ask RNs when I'm in a hospital setting. So, how many patients are assigned to you this shift? Right? Okay. And their response was about 4. And that was consistently their response, and they worked 12-hour shifts, so whether it was the 7A to 7P or the 7P to 7A, they consistently responded 4. And I said, are you always assigned about 4 patients? And they said, when we're really, really busy, it might be 5, most is ever that we get is 6, if somebody calls in sick or whatever. So it's an indication of how finally, this body of evidence about RN staffing levels and outcomes in hospitals is starting to take hold and to take root. And so just hold on to that little story for just a moment. I would then, by the way, tell them my story. Well, when I was a nurse on a med-surg floor, and I was a young nurse back in the 1970s, do you know how many patients were routinely assigned to us back then? And they said, no, not really. And I said, 20. All right, 20. That was pretty much, those of you who are the same, yeah, that's about what we did. And they're like, no, that never happened. And I said, oh, believe me, it did. And then they would respond, well, didn't that impact patient safety? And I'm like, yeah, hello. But you can thank, I would tell them, you can thank nursing research that you have 4 and you take it for granted. All right, so just keep that in the back of your head for a moment. Okay, so again, our job here is to present to you the evidence, and I'll be presenting representative studies that represent a body of evidence, study after study after study. And it is up to us as a profession. It is up to us as citizens. It is up to us as stakeholders then to take that evidence, regardless of the issue we're considering or the problem that we see, whether it's a clinical issue, whether it's a staffing issue, whatever that issue is, our first step should always be to look at the evidence regarding that issue, because clinical decisions, policies, should not be opinion-based. They should be evidence-based. And it's our responsibility as the largest group of healthcare providers in the United States, as nurses, it's our responsibility to leverage that evidence and to have our voices heard. So, one other thing about evidence before we move on, and this is something I always tell my PhD students and our colleagues always say, just remember, be cautious. One study does not a body of evidence make. One study might be very important. One study might be representative of the real world, but one study is one study. And there's no such thing as a perfect study. But when study after study after study in multiple settings, in multiple countries, multiple hospitals, and multiple centers show the same results, then that's evidence that we really should not ignore. So we really should pay attention to the body of evidence. And that's what I'm going to present now in hospitals, and I'm going to represent just some of the more impactful and more recent studies that represent 21st century hospital settings. So RN staffing in hospitals, does it matter? Well, you will see that the evidence supports that it does, but the model that's used is actually very, very simple. And this is actually Aiken's model, and what she says is that when nurses aren't spread out all over the place, when they have fewer patients on which to concentrate, they have better processes of care. In other words, they take better care of their patients because they have more time to do so. When you're running up and down the hall, when you've got 12 patients, or in my case, 20 patients to take care of, the amount of time that you can spend with one patient is very minimal. And you might very easily miss something in their care. You're not able to necessarily observe and detect small changes in their condition that indicate something's going wrong. So we're not able to intervene as quickly, for example, and that ultimately impacts patient outcomes. Very simple model. There we go. So I'm just going to share with you the results of a study, and this is one of the first studies in the 21st century that really started to get people's attention. And in fact, the findings from this study were published on the front page of just about every newspaper in the United States. This study was published in JAMA, which is another way that you can kind of evaluate the quality of the evidence of a study. JAMA is a journal of the American Medical Association. How easy do you think it is to get published in JAMA? Right, it's very, very hard. Right, they only publish the most rigorous studies. So you can kind of determine that if it's published in JAMA, it was probably a very well executed study. And this is looking at hospital nurse staffing and patient mortality. Now, when it comes to patient outcomes, nothing is more serious than mortality, right? That's the one thing that we, in many cases, try to avoid. So hospital nurse staffing and patient mortality, nurse burnout, and nurse job dissatisfaction. So this was actually inspired, this study, by talks about the California staffing legislation. Back when the legislation was first discussed, that would mandate RN staffing ratios in acute care hospitals in the state of California. And we were looking around and decided that there was a lot of concern about that possible legislation at that time, that it wouldn't be effective, that it would cause a lot of negative unintended consequences, et cetera. And so the team at Penn thought a more recent and current study, a very rigorous large-scale study, was in order. And so this was conducted in 168 Pennsylvania hospitals, 232,000 surgical patients, and RNs, over 10,000 RNs surveyed on the number of patients that were assigned to them on their last shift. Multiple nurses per hospital responded so that their responses could be averaged, or what we call aggregated, to the hospital. All right, they indicated where they worked, and then we could match their responses on staffing, on their current staffing ratios to actual patient outcomes in that hospital. So what did they find? That compared to 4 patients per RN, when that workload was increased to 6 patients per RN, there was the likelihood of a 14% increase in patient mortality. And when that ratio was elevated to 8 patients per RN, compared to 4 patients per RN, there was a 31% increase in patient mortality. Now I ask you, if that were your loved one in the hospital, if that were your loved one who required surgery, like my husband did 3 weeks ago, what kind of ratio would you be looking at? What kind of ratio would you want to see? So do you understand why I asked the nurses? Just how many patients are assigned to you on this shift? And fortunately, For our family, that number was 4, and for all the other patients in that hospital. And that is becoming more and more and more the standard that we see. These findings, like I said, were published. These findings were published on the front page of just about every newspaper in the United States. And my father, who at the time was in the early stages of Alzheimer's in North Carolina, picked up the phone and called me, and he said, "So, let me make sure I have this right. What you guys are saying is that when nurses have too much work, too many patients to take care of at one time, patients suffer." And I said, "Well, yeah, that's pretty much it in a nutshell." that kind of wraps it up. So I was amazed at the amount of interest that there was across the country in this study, and things just incrementally begin to change. Okay, now the next study was published a few years later in 2010, and actually I was a co-investigator on this study. I had finished my postdoc, and its implications of the California nurse staffing mandate for other states. And again, this study was published in a journal called Health Services Research, and for those of you who might not be aware of it, that is the journal that most policymakers read. Most politicians, senators, congressmen, et cetera, in Washington, D.C., their congressional aides read this journal in order to advise their representative. So this was funded by a grant from NIH to Dr. Aiken and a grant to me from the Robert Wood Johnson Foundation. And at that time, the California mandated ratios in hospitals now, acute care hospitals in California, went into effect 2004. These data were collected around 2006, 2007, so about 2 years after it went into effect. And thank you, California. California was the first state, as far as we know, in the United States to implement ratios in hospitals. I thank you, my family thanks you, much of the country thanks you. And in a sense, this study represents what we call a natural experiment, because for some factors or variables, we had pre-California legislation data and post-California legislation data. So we were able to do some comparisons. So this particular study involved 604 hospitals and a total of 22,000 nurses. So 353 of the 357 California acute care hospitals at that time were represented in this study, as well as 73 hospitals out of about 75 in New Jersey and 178 hospitals in Pennsylvania. We were able then to average nurses' responses to each hospital in these 3 states, and then merge those responses with data from the American Hospital Association, and importantly, each state's health department data on surgical mortality. Over 1 million patients, surgical patients, were looked at in this study. So this is very large, 3 states, over 1 million patients, very comprehensive. All right, and what we found, to our embarrassment, Charlotte, us Jersey girls, is that New Jersey did not look very good in this study. You can see that on med-surg units, for example, the average number of patients an RN cared for on New Jersey med-surg units was 6.8 compared to 4.8 in California. Even more than what was in Pennsylvania, which is considered to be a slightly more rural, perhaps less sophisticated state. So all these little asterisks under California, that means that their patient per nurse ratio was significantly lower than those in New Jersey and those in Pennsylvania. At the time, neither New Jersey nor Pennsylvania had staffing ratios for acute care hospitals. So, what does all this mean? Well, this is just another way of saying the same thing. For example, in New Jersey, on med-surg units, Only 19% of RNs in New Jersey indicated that their patient-to-nurse ratio was at or below the California mandate. Only 19%. 80% were above the California mandate, for example. So again, New Jersey looks pretty bad. It's even worse than Pennsylvania. Prior to the implementation of staffing ratios in acute care hospitals in California, there were a lot of concerns. What would this policy, this mandated ratio, do? Some people were very concerned that it would mean that the number of RNs per hospital would actually be reduced and LPNs would be increased, because in this legislation, LPNs counted in the ratio. Some people were concerned, for example, that the amount of support staff would be reduced. Sure, RNs would have a lighter patient load, but they would lose their unit clerk and other support staff that they had. Or that RNs would be floating to other units at a much higher rate than pre-legislation. And what we found, for the most part, is those concerns were not realized. That simply did not happen. For example, 70% of the California nurses said that the frequency of floating to other units either stayed the same or decreased. 85% of RNs in California that were in this study said that the use of LPNs either decreased or remained the same. So their jobs were not replaced with LPNs. And for example, 73% of the RNs in California said that their support staff either increased or remained the same. So a lot of these fears were simply not supported by the data. However, what was supported by the data was a significant association between the patient-to-RN ratios across the 3 states and adverse nurse-reported events, such as being abused, verbally abused by patients, increased family complaints, high burnout scores that we measure with reliable and valid instrument that is used internationally, higher reports of job dissatisfaction, higher reports of missing important changes in their patient's condition, and higher reports of poor to fair quality. All of these things were associated with higher patient-to-RN ratios. And this is the money shot. This study concluded, based on very sophisticated statistical analysis and a team of about 10 seasoned researchers and statisticians, that if the average patient-to-RN ratio that California enjoyed had been in place in New Jersey and Pennsylvania, there would have been 13.9% fewer surgical deaths in New Jersey and almost 11% fewer surgical deaths in Pennsylvania. This is the finding that went nationwide. And this study and all of the studies that came before it are basically the reason that those nurses who took care of my husband were enjoying a 4-patient to RN ratio and took it for granted. Didn't even know about the days when we had 20 or 12 patients apiece. So I'm going to share one more, I think it's one more acute care hospital story with you, or study with you. This one was published in the British Medical Journal, BMJ. Again, another very prestigious journal that is hard to get published in. And so you can be assured that this is very rigorous, and this was just published last year. This study took place in 6 European countries, so now we're expanding the evidence beyond the United States. England, Ireland, Belgium, Switzerland, and Spain. 188 hospitals, almost 19,000 patients. And the backstory to this is that Europe was saying, okay, fine, we get this ratio thing in acute care hospitals, but does it really have to be an RN? I mean, isn't it about the patients per nursing staff person? It doesn't have to be an RN. It could be a CNA or a patient tech or something like that. So they were talking, there was a lot of talk in Europe about substituting one RN on each floor for a tech or a CNA or something like that, thinking that they would still be maintaining a good level of patient safety. And so what this story looked at was the baseline at the time, RN to patient ratio, which was 6 patients to 1 RN. They had read those US studies and they had leveraged that evidence. And what they found was a lower RN skill mix below that level was associated, yet again, with a higher likelihood of inpatient mortality. And in fact, a 10% reduction in RN skill mix resulted in a 12% increase on odds on mortality, and a 16.7% reduction in skill mix resulted in a 21% increase on odds of inpatient mortality, which means that you can't just substitute an RN for an aide, or substitute an aide for an RN. Skill matters. All right, I'm going to talk a little bit about missed care. And missed nursing care is care that patient is supposed to receive but didn't receive because the nurse didn't have time. That's the bottom line on missed care. And this, I would say, is an emerging body of evidence. The evidence about RN staffing in acute care hospitals, that is a huge body of evidence. Study after study after study in the United States and in other countries have demonstrated that association is significant and lasting. Missed care, those studies are just emerging. But it is believed that missed care is sort of the mechanism by which staffing affects outcomes. Nurses, if you have a high patient load, you just don't have time to do all the things you're supposed to do for a patient. It makes intuitive sense. And so a study published last year found that 4 or less patients, compared to 10 patients assigned to a nurse, reduces the odds on miscare by 85%. We are finding preliminary findings in nursing homes, and that is a PhD student that I'm working with who has collected and analyzed her data, and she'll be defending that dissertation research next month. But she has found a significant association between patients per RN, direct care RNs in nursing homes, and miscare. And then there is a growing body of evidence that we should care about missed care, that it results in poor patient outcomes, including readmissions and including other adverse events. So let me move on then to another focus of our work, which is a supportive work environment. We talked about staffing in acute care hospitals. What about the work environment? And again, I go back to the model. A supportive nursing work environment has basically, according to this model, 5 pillars, 5 major characteristics that represent a supportive culture in which nurses can work. One is having enough resources to do your job. Have you ever been in a job where you were really trying to do a good job and you just didn't have the resources to do it? That's what we mean by having enough resources, resource adequacy. And it is part of an organizational culture or work environment. Good and collaborative nurse and physician relationships, where nurses and physicians actually talk to each other, respect each other, and collaborate on patient care issues. Something that we call foundations for quality, and this is the infrastructure of the organization, that there's a good and effective orientation for staff, that there is support for nurses' continuing education, that there is a good quality improvement process in place, and things like that under the rubric of foundations for quality. The 4th pillar is that nurses have an effective and heard voice in organizational decisions. Not that they're just some token person on a committee of 20 physicians, but that they actually have a voice that's heard by the administration and they have an input into organizational decisions. This is a culture that that fosters professional nursing practice, and research has shown that this is a culture in which nurses want to work. And last but certainly not least, that the nurses have a supportive and competent frontline nurse manager. That is what we consider the essential characteristics of a supportive nursing work environment. That influences the care that nurses give. It ultimately influences patient outcomes and ultimately nurse outcomes, such as job satisfaction or lack thereof. So, does it matter? And there is a growing body of evidence with respect to work environment. And I would say this is an emerging body of evidence, but we're seeing more and more of it. These are all, or the last two that I'm sampling here, were just published last year. The first one ever to make this case was published in 2008, and they found in 168 hospitals that the likelihood of 30-day patient mortality was 14% lower in hospitals with a supportive work environment than hospitals with a non-supportive work environment. Last year, Matt McHugh published this very large study, 75 hospitals in 4 states, 11,000 patients, and found that patients in hospitals with poor nursing work environments, where those 5 pillars were not present or not present very much, had a 16% lower likelihood of surviving an in-hospital cardiac arrest. So these studies indicate that the work environment matters not just to nurses, but to patients as well. And this last study, published last year, was headed by Jeff Silber, who's not a nurse. He's a physician and health services researcher, and he did a very comprehensive study in 328 hospitals in 4 states, looking at outcomes of 88,000 patients, and found that hospitals with a supportive nursing work environment had significantly lower inpatient mortality, 4.8% instead of 5.8%, for a similar 30-day cost. And when you think about the bottom line, when you think about the things that comprise a supportive organizational culture, nurses having input into decisions, nursing having a supportive frontline manager, having good collaborative relationships with physicians, those things are not necessarily costly. Those things need to simply be expectations, part of the culture, not necessarily an increased cost. And that is what Jeff Silber's study indicates. So I'll just share with you a couple more studies, and then we'll move on to something else. In this particular study, I was the principal investigator on it, and it looked at the work environment and its impact on medication errors, conducted it in 14 hospitals, 82 med-surg units. All right, and what I found is that in a supportive nursing practice environment, nurses are more likely to identify and intercept medication errors before those errors reach the patient. I was fascinated by a study that was done several years ago where they said, oh yeah, and this was conducted by physicians and health services researchers, and they're little sort of like after the major findings, they reported, oh yeah, and by the way, 86% of the would-be medication errors were actually intercepted by nurses before they reached the patient. So nurses are extremely important in intercepting those errors before patient harm is done. And in this study, a supportive nursing practice environment was significantly associated with nurses' ability to do that. And by the way, just when you're looking at evidence, you see that last column that says P, and then it has 0.001 or 0.000. What that means, that 0.001, is that there is only one chance in 1,000 that the findings are a fluke, that the findings are something special about the sample or something particular to that particular setting. And a 0.000 is that there's less than one chance in 1,000 that basically the findings are a fluke. So that is something else to look at when you're looking at studies. And last but not least, we found that in those hospitals, on those units where the nurses' interception practices were the highest, guess what? There were fewer medication errors that actually reached the patient as documented medication errors. So nurses make a difference in intercepting medication errors and preventing patient harm, and the work environment helps them do that. It is part of the culture in which they work. So, what about medication errors? Who cares if the patient didn't suffer an adverse event because of the medication error? And most medication errors do not result in an adverse patient event. Then, do we really care about that? And so we continued, and one of my team members was a pharmacoeconomist, and so he took the lead on this analysis where we looked at the cost of medication errors, not necessarily adverse patient events related to medication errors, but the actual medication error itself. Because we hypothesized that if a medication error is documented, regardless of whether the patient has a negative reaction, the hospital is going to do some things to kind of protect the patient. They might keep the patient a day longer. They might order some additional lab work, or some extra thing is going to be done when they find out a medication error has occurred. And in fact, that's what he found. Looking at 57,000 patients from 2 hospitals over a year, he found that the average cost per medication error, regardless of whether it resulted in an adverse event or not, was over $8,000. So yes, we want to prevent medication errors for the patients and for the bottom line. So what about non-acute settings? Does the work environment matter? Yeah, when we looked at it in nursing homes, and this was 63 nursing homes in New Jersey, we found that in supportive practice environments, there was a fewer prevalence of pressure ulcers in nursing homes. And in fact, 4 out of those 5 pillars of a supportive work environment were significantly associated with fewer pressure ulcers across 63 nursing homes. And we also found that there was a difference in the work environment, in the organizational culture, between nursing homes that were for profit versus nursing homes that were not for profit. Now, don't get me wrong, I have nothing against profit. I love profit. I love to go shopping. I spend profit, okay? That's not a problem. When it affects the culture in which we work, which ultimately affects patient outcomes, like the prevalence of pressure ulcers, then it's a problem. So we simply need to look at, for example, for-profit nursing homes. It doesn't cost that much to change the culture. It doesn't cost that much to expect collaborative relationships between nurses and doctors. It doesn't cost that much to give nurses a voice, hear their input with respect to organizational decisions. Those things, at least on the surface, are not costly. So we need to look further at that and how we're going to handle that. Also, the work environment was associated with a number of deficiencies found by the State Department of Health across the 63 nursing homes. Better work environment for nurses, fewer deficiencies. All right, what about Medicare certified home health? And this was published in Medical Care, again, not a fly-by-night journal. And we looked at 118 home health agencies in 3 states and joined those data, merged those data with CMS patient outcome data. And what we found, again, is that a supportive work environment was associated with fewer rehospitalizations among patients who were admitted to Medicare certified home health. So again, let me just summarize by saying that when we look at other settings, acute care hospitals, for example, staffing ratios, in other words, nurses' workload, the number of patients assigned to RNs, matters in terms of patient outcomes. And again, I thank you, my husband thanks you. Work environment across settings, acute care hospitals, nursing homes, Medicare certified home health matters. And work environment is really an indicator of organizational culture, the degree to which those 5 pillars that support nursing practice are present. So at this time, I would like to welcome to the podium my research partner and long-term friend and awardee of the American Nephrology Nurses Association Lifetime Achievement Award, Dr. Charlotte Thomas-Hawkins.
So we're keeping an eye on the time, and we thought 90 minutes is a long time for you to listen to us. And before I translate the evidence that Linda has presented to you, I'm wondering, as you're thinking about work environment in hospitals, what do you think is important in dialysis units to support nursing practice? What kind of characteristics do you think should be present in dialysis environments that would be supportive of your practice? Do you have any thoughts or comments about that? What? I heard strong what? A strong union. Any other comments? Training. Anything else? Resources. Okay, so I'm hoping that we can have some discussion when I get done. But again, I just wanted to share with you, in terms of the dialysis work environment, that my nursing career, after I graduated, got done with my basic nursing diploma, I worked in an acute care hospital for a long time. I live in New Jersey, but I worked in Philadelphia. And I found myself as a new nurse on a medical floor, but it was a floor that all the dialysis patients were admitted to when they were hospitalized, and we actually had 3 peritoneal dialysis beds. And I found as a nurse that I kind of liked dialysis patients. I found them what I called needy. They seemed to need a lot of teaching, and they helped to make me feel autonomous as a nurse because they didn't seem to need the physician as much as they needed the nurse. So I worked there for a long time, and when I finished my master's degree, an opportunity opened up in the hospital of the University of Pennsylvania's outpatient dialysis unit. And for the first time, they were going to hire an advanced practice nurse. Since I knew all of the nephrologists from the medical floor that I worked on, and I had my master's degree, I said, okay, I'll do it. And so after having numerous years of experience in an acute care hospital, in which I didn't know at the time, but the type of environment that I worked in was a supportive work environment, because the practice environment scale had not yet been published. And so I found myself, on the first day that I was in the outpatient dialysis unit, I had never worked in an outpatient setting. And it took me about a couple of weeks, but the one thing that was very striking to me and noticeable was that nursing is different here. I mean, it was a culture shock to me. I didn't know what to expect. I had been used to the acute care dialysis unit in the hospital, but I had never been exposed to an outpatient dialysis unit. Now, the nurses in the dialysis unit were employees of the hospital, but the dialysis unit was managed by one of the 2 large dialysis organizations that it lists today. And so we were geographically distant from the hospital, employees of the hospital, but what I noticed was different about nursing was that there was less nurses than the unlicensed personnel, that there were more technicians than nurses. This was new to me. In the hospital, there were always twice as many RNs as there were nursing assistants. And so one of the differences, boy, there's few nurses here. The other difference seemed to be, even though they were employees of the hospital, they seemed to be isolated in the dialysis unit. The nurse managers did not meet with the nurse manager group in the hospital, something that I was used to. As a nurse manager in the hospital, the staff just had staff meetings among themselves, and so the nursing staff seemed to be very isolated in that geographic building. And it took me a while to understand what this managed by a large dialysis organization meant. When I understood what that meant, to me it meant, okay, so that organization is the hospital, if you will, that organizes how staff is structured in dialysis unit. And the organization was multiple states away. So it was hard for me to really understand that. And the other noticeable difference was I was hired by the physician group to help manage patients for the nephrologist. And so they came in and they rounded, and then they left. I worked in a hospital that was an academic medical center on an Ivy League campus, and on my unit in the acute care hospital, there was always a physician present. So if the nurses needed help with the patient, they just either yelled out or walked down the hall, or the physician was a minute away if you paged them. And I was just struck that the physicians left. And I looked around and I said, so it's the nurse. Most of the time, because the physicians only round it once a week, and it was a 36-station unit, 3 shifts a day, and physicians rounded on every shift, but it was only once a week that they were there. And so for me, it was a culture shock to have nurses in the unit managing patients independently without a physician presence. Of course, the patients were ambulatory. They were not acutely ill. But as the advanced practice nurse, I was the one that managed the problems. And there were many, especially in patient shift change, because they would come and get me. So even though the patients were ambulatory, we sent patients to the emergency room. Patients came with thrombovascular accesses, and they had medical problems. That's why they were on dialysis. So they would come with medical problems, and it was the nurse that typically had to manage the problem with the physician on the phone distantly or me. So one of the things that I was really impressed with when I first worked into the outpatient dialysis unit was the important impact that nurses had on the patients. And I knew that nurses knew that intuitively. And I didn't think that I was asking a research question at the time. But one of the things that I understood in an outpatient dialysis unit that dialyzed over 72 patients a day, 6 days a week, and the professional in the unit was the nurse, that this nurse had an important impact on patient outcomes. And it was more that the patient got dialyzed adequately, that these patients came in with chronic medical illnesses. And coming from the acute care hospital, what I saw those nurses do was manage chronic illness. Not just do dialysis, but they were there managing chronic illness to try to keep patients out of the hospital. And so the question for me was, does nursing matter in hospitals? And certainly, I had the answer to that question, but I knew that there was not data. And so after I was done with my PhD, I used to be the research consultant for the American Nephrology Nurses Association. And in that role, I had oversight over the research committee and the clinical practice committee. And Linda talked about the 2002 article that was published in JAMA, and I heard it on the news. And I actually was in the PhD program with Eileen Lake, who is the author of the Practice Environment Scale. And that Practice Environment Scale was published in 2002. So I thought, as the research consultant, I think this dialysis work environment matters here. So let's look at this practice environment scale that's been used in hospitals, and let's modify it, and let's ask nurses how supportive they think the dialysis work environment is for professional nursing practice in dialysis units. And so we simply modified some of the items on the scale, and the American Nephrology Nurses Association distributed the practice environment scale to staff nurses who were members of the American Nephrology Nurses Association. It was a simple study. The major purpose of the study was to assess the extent to which nurses who worked in dialysis deemed that the dialysis work environment was either supportive or not supportive of professional nursing practice in dialysis units. And so we sent out one survey, and typically in research, if you want to get a good response, you send out multiple surveys. But with just one survey distribution, we got about 400 nurses who responded to the survey. 74% worked in for-profit dialysis units, 19% worked in not-for-profit dialysis units, and at the time, 6% of nurses who responded to the survey were unsure of the ownership type of their dialysis unit. We use the same scale that Linda Flynn described, the practice environment scale, but I remember at a national meeting, the members of the clinical practice committee, we sat down around a table just like this. We took the items and we changed just minor wordings on the items to fit an outpatient dialysis unit. And so the input into hospital affairs, we changed that to nurse participation in dialysis, provider affairs, and just like the practice environment scale used in hospitals, what the items on that scale do is reflect the extent to which staff nurses in dialysis units have the opportunity to participate in decisions in the larger provider organization. And some of the items on the scale, I have them listed here, that we asked nurses to rate whether or not this characteristic was present in their dialysis work environment, is staff nurses are involved in the internal governance of the dialysis unit. There's an opportunity for nurses to participate in policy decisions. Coming from an acute care hospital, that was not my experience in the dialysis unit. Remember, they were isolated in a community and really didn't seem to communicate with other nurses. I came from an acute care hospital in which I was on hospital level committees. Nurses had an important role in policy decisions that affected professional nursing practice. Another item is there's a nurse in a senior management position in your organization that is equal in power and authority to other top-level executives in the organization. And what distinguishes a supportive practice environment is that you have a nurse executive whose role is to articulate what nursing is in the organization and to make sure that that is reflected in all of the policies that reflect professional nursing practice. Another example of an item in which we asked nurses to rate whether or not there was participation in dialysis provider affairs is that there's an administration that, and I'm talking about an organizational administration, that listens and responds to employee concerns. We modified some items on the Nursing Foundations for Quality of Care, which emphasizes that there are structures in place that emphasize a high standard of nursing care. And some of the items were that there's an active quality assurance program, there are high standards of nursing care that are expected by the administration, and you have nurses who are working with other nurses who are clinically competent. The nurse manager ability, leadership, and support scale, the items were similar, and some of the items were supervisors use mistakes as learning opportunities and not criticisms. A nurse manager in the unit is a good manager and leader. There's a nurse manager who backs up nursing staff in decision-making, even if the conflict is with the physician. The staffing and resource adequacy is, we didn't change the items on that, and some of the items is that there are adequate support services that allows me to spend time with my patients, that there's enough registered nurses to provide quality patient care, and that there's enough staff to get the work done. And lastly, RN-MD relationships. Those items just reflected whether or not there were collegial and good working relationships with nurses and nephrologists in the dialysis unit. And so these are the findings from that early, and this is early in 2003. And you can see that the practice environment scale, when we asked nurses to rate the presence in which each characteristic is present in their work environment on a 1, never not present, up to 4, which is that they strongly agree that the characteristic is present, you can see that there wasn't strong endorsement about the extent to which the dialysis work environment was supportive of professional nursing practice. The pillars that were rated the lowest was nurse participation in the dialysis organization affairs and also staffing, resources, and adequacy. But if you look at the Nursing Foundations for Quality of Care and the nurse manager ability, leadership, and support, again, that was what I call moderate or lukewarm endorsement. You don't see that the mean scores are above 3 and close to 4, which really reflects a supportive work environment. We also asked nurses if they plan to leave their job in the next year. And you can see that a majority of nurses did not plan to leave their job, but 19% did. And for me, that's 1 out of 5 nurses. And if you're a nurse manager and you have 1 out of 5 nurses always wanting to leave the job, that's very costly. To replace those nurses and train nurses. So for me, 19%, even though it was not a majority, 1 out of 5 nurses planning to leave their job, 20% of your nursing staff, I think is pretty significant. So we also compared how nurses rated the work environment by whether they plan to stay or whether they plan to leave. And the green bar are nurses who plan to stay, and the brown bar are nurses who plan to leave. And you can see across all those pillars of the work environment, nurses who plan to leave their work their job in the next year rated their work environment as least supportive compared to nurses who plan to stay in the next year. And so this early study certainly suggests that the dialysis work environment that has characteristics supportive of professional nursing practice are important for nurses. And the findings suggest that certainly a supportive practice environment in dialysis units matters for nurse retention in dialysis units. I can tell you that this study was a seminal study. Again, it was supported by ANNA. I conducted it in my role as the research consultant for ANNA. So a summit was actually convened by the American Nephrology Nurses Leadership, nursing leaders in the nephrology community, dialysis provider leaders in the dialysis community were invited to come to Washington. And I can tell you it was before the major consolidation of the dialysis industry into 2 major large dialysis provider organizations. And we presented the work, the findings from this study. And so I would say at best, it certainly raised the consciousness of nephrology leaders about the importance of a nursing practice environment. And it certainly, I heard nurses in the audience begin talking about what a magnet dialysis nursing environment was. But I'm not sure it had a lasting effect. And I would suggest to you that certainly the effect was short-lived. I myself was invited to one of the now smaller dialysis organizations by the medical director of that organization to come right after the meeting and talk at their annual meeting. But again, that was back in 2005. We're in the year 2017. There certainly has been a major, I think, consolidation of the dialysis organization. So I think the effect of our first article on any change in the work environment in dialysis organizations was short-lived. And so what about RN staffing and missed nursing care and the effect of that in dialysis units? It certainly seemed to matter in hospitals. And for me, I thought, and my hypothesis was, that I think that it matters in dialysis units as well. And so the study that myself and Linda Flynn was on faculty at the time at Rutgers University. So I was a nephrology nurse researcher, and she was the health services researcher. And I went to Linda and said, quite frankly, I think I need help. You know, I think that we can take the model that you're doing in your research and translate it to dialysis environments, because I think nursing matters here, and so Linda and I began our journey on trying to gather evidence about the importance of nurses and nursing care in dialysis units, and this study was funded by the American Nephrology Nurses Association. And the purposes of the study was to determine the relationship between RN staffing and mixed nursing care in hemodialysis units, and then determine the impact of RN staffing and the impact of mixed nursing care on the odds of nurses reporting frequent adverse events in hemodialysis units. I can tell you, I think the impact of Linda Aiken's work and translating this model to a dialysis organization is that we do nurse surveys, and that because we believe that nurses, dialysis technicians who are closest to the patients can report their experience. And so I think one of the strengths of the model that we use is that we ask nurses about their experience on their last day worked, because we think that most people will remember what staffing was on the last day worked, what care they missed on the last day work. And so that's the model that we have used as well. In this study, 422 members who were members of the American Nephrology Nurses Association responded to our study, who identified themselves as staff nurses. We had over 1,000 who responded to the survey. 53% worked in corporate freestanding dialysis units, 27% were in hospital-owned, hospital-based units, and about 20% worked in hospital-owned freestanding dialysis units. We used the same measures that were used in Linda Flynn's work. We measured nurse staffing by asking nurses on the last day worked, how many nurses were there on a patient shift that work with you, staff nurses. We also asked how many patients you were in the dialysis unit on a patient shift. We asked how many technicians there were on a patient shift and how many LPNs there were, if any, on a patient shift. So we could calculate the number of nurses per patient, the nurse to patient ratio. We asked about miscare. And this is a series of items that ask about whether or not you were able to check all of the activities you were not able to do because you were simply too busy to do them on your last day worked. And they're a total number of 7 tasks. And so the total score was 0 to a 7. 0 means that you missed none of them, and up to 7 means that you missed all of them. And these are the activities that we asked the necessary activities. Important patient and family teaching. Did you talk and comfort patients? Did you do important documentation? As a nurse, were you able to provide adequate supervision of technicians? As a nurse, were you able to provide adequate monitoring of dialysis treatments? As a nurse, were you able to provide adequate patient surveillance? And were you able to coordinate patient care? For our nurse-reported outcome measures, we asked nurses about 13 adverse events, the frequencies based on their experience that occurred in their dialysis units over the past year. From 1 never up to 7, the frequency occurred almost daily. And these are the adverse events that have certainly been deemed in the literature as events that are very important for patient outcomes and adverse events. And so these were the RN, the patient to RN ratios reported in quartiles. And you can see they varied across the dialysis units. But you can see that the largest group, 31%, reported greater than 12 patients per RN. And that was my experience in my dialysis unit. We had 36 stations, 3 bays, and there was always 1 nurse per bay. And sometimes if a nurse called out sick and they could not replace that nurse, a nurse had more than 12 patients. And so for me, nurses always had 12 patients. and they might have more during a patient shift. And so the nurses in my dialysis unit, if they responded to the survey, were part of that 31%. The percentage of nurses that reported tasks left undone on their last day worked, as you can see, 60% of the nurses in the survey said that they weren't able to provide important patient teaching. 50% said that they weren't able to talk or comfort patients. 26% said that they were not able to complete important documentation. 25% said that they were not able to provide adequate supervision of technicians. That's a lot. 20% said that they were not able to adequately monitor dialysis treatments. As you can see, we asked nurses, and what these bars represent are the percent of nurses who reported miscare. And you can see the majority of nurses, 35%, said that on their last day worked, they were not able to complete 3 or more of the tasks that I had listed on the slide. And so what was the impact of RN staffing on tasks left undone? And we looked at the 31% of nurses who said that they left work not completing 3 or more tasks left undone, and we divided those nurses by their nurse-to-patient ratio that they reported. And you can see that the majority of nurses that left the most missed care had the highest nurse-to-patient ratios. Similarly, we looked at the frequency of adverse events, and these were the 4 most frequently reported adverse events. And certainly my experience in the dialysis unit is that the nurses got these right. You know, that the frequency of skipped and shortened dialysis treatment in my dialysis unit was fairly high, and dialysis hypotension was a very frequent adverse event that I would have to deal with in the outpatient dialysis unit. And so the RN staffing and miscare certainly had a significant effect on the odds of nurses reporting those frequent adverse events. And what these numbers basically mean are the odds of nurses reporting who had large nurse-to-patient ratios compared to nurses that had 4 or less patients. And you can see that when nurses had large nurse-to-patient ratios, that the odds of reporting short and skipped treatments were 3 to twice as likely compared to nurses that had less patients, and the same for the odds of nurses reporting adverse events when they missed 3 or more tasks left undone compared to nurses who missed no tasks undone. Those nurses had a higher likelihood of reporting adverse events in their dialysis units. And so to summarize these findings, certainly low RN staffing was significantly associated with nurse reports of adverse events. Low RN staffing was significantly associated with higher numbers of tasks left undone or miscare. Miscare was significantly associated with nurse reports of adverse events, and when you took those in combination, both miscare and low RN staffing significantly predicted adverse nurse events independently in dialysis unit. And it was this study that got us to CMS, the president of the American Nephrology Nurses Association at that time. Her focus was nurse staffing in dialysis units, and we took these findings before they were published. We were invited to come and talk to the staff of CMS. At the time, the person who headed CMS was a nephrologist, and so they asked us to write a white paper because we hadn't had our findings study. It was at the time that conditions for coverage were out for public comment, and the pushback that they were getting from the dialysis provider organization about having one nurse in the dialysis unit is that we're not going to be able to do that. We're going to have to close dialysis units. We're not going to be able to find nurses. This is going to be difficult. So there was a lot of pushback. But it was our study that CMS decided that instead of having a nurse, and it didn't matter if it was an RN or an LPN in the treatment area during the dialysis treatment, you needed at least one RN, despite the pushback from the dialysis unit. And I can tell you, at least anecdotally, that once those new conditions for coverage came in, I don't think dialysis units closed. I mean, my experience, certainly in New Jersey, is that I have seen a dramatic increase in the number of dialysis units as I ride home. And I tell you, I have a long drive home. I live about 70 miles from Rutgers, and I see a lot of dialysis units in New Jersey that I didn't see 15 years ago. And so despite the pushback from the provider community for this changing conditions for coverage, the growth in the dialysis industry, at least from my perspective, has continued to increase. And so what about nurse burnout in dialysis units? Does it matter? I can tell you that Linda and I did a qualitative study of nurse managers, and I was the one who actually interviewed nurse managers. I could hear the burnout on the phone. I could hear it. And we just developed 2 scales to measure the practice environment support for nurse managers in dialysis unit and safety practices. And I tried to get my friend that I used to work in the dialysis unit in Philadelphia to rate the scale. She's a nurse manager in a dialysis organization. That's a large dialysis organization. And she said, it's not a good time to ask nurse manager, Charlotte. Just not a good time. We are stressed. I could, again, hear the stress on her phone. And so we had measured nurse burnout in dialysis units in our analysis, and I'll quickly present the findings. The purpose of the study was to describe the prevalence of burnout, and I don't think anybody had done that prior to this study, and determine the effects of nurse staffing, workload, practice environment support, and miscare on RN burnout in dialysis units, and also to determine the effect of RN burnout on a nurse's intent to leave their job. Workload we measured, and Linda talked about the measurement of workload, and you have to understand that workload is different than staffing. If any of you have worked in an ICU, you know that the number of patients you're assigned to is less the number of patients in a nurse on a med-surg floor, but her workload can still be high, despite the number of patients that she has. And these are the items that we use to measure workload. We expect that staff are going to be able to take a 30-minute break, right? During the day. If I'm a patient in a dialysis unit, you know, and you've been here for 5 hours, I hope you took a break if you're going to make an important decision about me. That's workload if you can't. Most days, my workload is unreasonable. If my mom's in a dialysis unit and it's about the 5th day that your workload has been high, I think I'm going to sit there right next to her. Because this nurse may be a nurse that doesn't have the time to pay attention to some important changes in my mom. My workload will cause me to look for a new position. My workload caused me to miss important patient care. And you can see the percentage of nurses on their last day worked reported a high workload. In terms of dialysis work environment support, again, you can see 36% of nurses reported their dialysis work environment is unsupportive, 34% is mixed, and that's where some said I disagree with the items and some said I agree. They didn't strongly endorse it, and only 29% reported the dialysis work environment as supportive. Look at the workload. 31% of staff nurses in the sample reported burnout, and 56% of nurse managers in our sample reported burnout. So I think at least what this study shows is that in the dialysis environment, there's a significant portion of nurses that may be suffering from burnout. And so what was the impact of burnout on workload? Again, this sample represents the nurses in our sample that reported a high burnout score, and you can see that the 59% of nurses who were burned out also reported a high workload. And so there's an important relationship between workload and burnout. I don't think I need to tell you that in the audience if you're working in a dialysis unit. The same relationship exists between burnout and missed care. That nurses who miss a lot of care also are nurses who report that they're burned out. And I think that the summary of these findings are important, that low RN staffing, high workloads, and an unsupportive environment were significantly associated with RN burnout, and that you can see nurses with the highest workload, nurses who work right at their environment as least supportive, and nurses who missed more care were more likely, either 5 times, 4 times, or twice as likely to report burnout compared to nurses who had low workloads, had low patient to RN ratios, and who did not miss care. Burned out nurses were also 3 times more likely to report that they plan to leave their job in the next year. So does burnout matter? Our findings certainly suggest that if nurse retention in a dialysis facility is a priority, then efforts should be implemented to minimize burnout. And I think that that is a better investment in money than training new nurses when you have 20% of your nurses who plan to leave your job at any given time. And so the last item we looked at is patient shift change. And this was important to me because of the advanced practice nurse. This is when I was the busiest. When patients were getting off of the dialysis treatment and they were hypotensive and there were other problems with their vascular access. And then patients were coming in with chest pain or problems. And you all know that it is a high volume, error-prone time in dialysis units. And so we measured patient shift change safety in dialysis units and wanted to look at the extent to which nurses thought that these nursing indicators was significantly related to the safety during patient shift change. These are the items that we use to measure patient shift change. We asked nurses about things falling between the cracks during shift change, important patient care information is lost during shift change, that shift change is problematic, and that problems often occur in the exchange of information during patient shift change. And what was the agreement? You can see that overwhelmingly, a majority of nurses agreed with those 4 items, that there was problems during patient shift change. Only 39% of nurses in the sample rated shift change as a safe period in dialysis units. And I can tell you that Beth Ulrich, recently, and some of you might have responded to this survey, distributed the hospital survey on patient safety culture to nephrology nurses. And I was really interested in looking at her findings, and I looked at the transition scale that she reported. It wasn't modified to reflect patient shift change, but a lot of the items did. And I can tell you, several years after we did our study, only 45% of nurses who responded to that survey reported patient transition in dialysis units as safe. And so certainly transitioning patients across settings and during patient shift change, the data suggests that it's a problematic period in dialysis units. When we looked at hospital-based versus corporate-owned, you can see in corporate-owned dialysis units, the mean score for patient shift change safety was lower compared to hospital-owned dialysis units. And we also found that miscare is an important pathway for the effect of RN staffing on patient shift change safety. RN staffing did not independently affect patient shift change safety, but it affected miscare that in turn influence the extent to which nurses rated patient shift change as safe. And so it's not that RN staffing is not important, but miscare, as Linda said, is a very important aspect of nursing care that has a negative effect, at least we think, on patient outcomes in dialysis units. We also found in this study that high workload and a supportive work environment affected patient shift change safety directly, that if you had high staffing and the workload and the work environment was deemed as supportive, nurses tended to rate shift change as more safe, compared to nurses who rated their workload as high and high patient to RN ratios. They tended to rate patient shift change safety as unsafe during dialysis periods. And again, as I said, that was my experience in dialysis units. That was a very high volume, error-prone period, and it occurred, at least in our dialysis units, 4 times. And we were transitioning, close to 90 patients 4 times a day in our dialysis units. And so it was a period that certainly lent itself to errors because of the number of nurses that were present in the dialysis unit. And so the summary of these findings is that workloads, work environments, and miscare are important for unsafe patient transitions during patient shift change in dialysis units, and that low RN staffing has an indirect on patient shift change safety through its effect on miscare. I mean, it's intuitive. You don't have enough nurses, you can't get all of your work done. Things happen to patients during this high transition of patients in and out of the dialysis units. Compared to nurses who rated patient shift change as safe, nurses who rated patient shift change as unsafe were up to twice as likely to report frequent occurrence of skipped and shortened dialysis treatments, vascular access bleeding, infection, and thrombosis in their dialysis units. And when I looked at these adverse events, to me it made sense that these are the type of adverse events that would occur during transitioning of patients in and out of the units. If staff are rushed, pulling needles or inserting needles, you may get inadvertent bleeding from the vascular access. If you're not monitoring patients and patients are putting too much pressure on their needle site, their access can thrombose. A lot of times patient treatments are shortened, not because the patient asked, but because the staff shortens the treatment because there's another patient that needs to come in. And we know that skipped and shortened treatments have an independent relationship with hospitalizations and mortality. And so those adverse events are important. And these nurses were almost 3 times likely to report patient complaints in their dialysis units. So does patient shift change matter in dialysis units? I think so. And we're beginning to gather the evidence that it does. So what are the policy implications for our beginning work in this area? We certainly believe that as health services researchers, the important objective of our work is to provide evidence for you all, to be aware and to make evidence-based decisions, to bring evidence and advocate for yourselves as nurses. But the other important work that we do is to influence policy. We hope systems need to change. And a lot of times we recognize that the only way systems change, I always say it, and I think this is my years of working in the hospital and my years of working in an outpatient dialysis unit, is that healthcare providers do what they're paid to do. And they're do what they're mandated to do. They just will. And so the way that we may be able to change health systems is to influence state, organizational, and federal policy. When the feds say that you have to do this, they'll do it. When the state says, and we have states, I am from a state that has mandated staffing regulations that came from the State Department of Health. Dialysis providers have no choice. They have to do it so that we know that we want to influence evidence-based policy decisions. And I can tell you in the state of New Jersey, I don't know how long they've had mandated staffing levels. As I said, I worked in Pennsylvania, but as a researcher, I've collected data in dialysis units for years. And as a nephrology nurse, I always ask nurses questions because I'm an observer in that role. I want to know how many staff nurses belong to the American Nephrology Nurses Association, and I can tell you the majority of staff nurses say no. And then I always watch, and in New Jersey, I became aware of the mandated staffing regulations when I was there collecting data, not related to our work, but related to earlier work that I was doing, and the nurse informed me of the staffing regulations, that we have to have 1 nurse per 8 patients, and we have to have 1 technician per 4. It seems to have been like that for a long time. Glenda Harbert, who couldn't stay for our session, she's from Texas, and Texas is another state that has mandated staffing levels. And so Linda and I asked her, and she said it happened in 1996, and she worked in the dialysis unit before the staffing mandate and after the staffing mandate. And certainly in hospitals, in my experience at HUP, when some of the workers wanted to belong to a union, I mean, what typically happens? I was a manager in the dialysis unit, so I was on the side of, no, we don't want unions. Unions bad. You know, and so there's always going to be 2 sides to a story. But I can tell you Glenda Harbert's experience, like at least my observational experience in New Jersey, is that things didn't seem to change. You know, Glenda said in Texas, they were threatened with dialysis units closing, with staff losing their jobs. The staffing mandate went into place, and nothing happened. Nobody lost their job. In fact, they needed more nurses, and dialysis units didn't close. And so the important part of our work, one important part of our work, is to influence policy. And we were very pleased that we were at least able to influence federal policy in terms of mandating 1 RN. We believe, and there may be some dialysis units, I don't know, that have 1 RN in a treatment area. I hope they only have 4 stations or 5 stations. We believe that there needs to be more, and we're hoping with our work we can provide more compelling evidence. We certainly think that nurse burnout and subsequently intentions to leave can be reduced by ensuring reasonable workloads. All of you are entitled to at least a 30-minute break a day. And if that doesn't happen on a regular basis, your workload is too high. We think that every worker, regardless of the profession or occupation that you're in, should have a reasonable workload so that you can take a break, feel that you can get the work done. And you should also be working in an environment in which you feel supported. And there also needs to be a routine assessments of safety culture in dialysis units to identify threats to patient safety and improve outcomes in patients. I can tell you, we asked nurses to rate the overall patient safety in their dialysis units. They rated that fairly high. I think 86% said that they felt that overall the dialysis unit was safe. But 39% rated patient shift change safety as unsafe. So what does that say about patient safety? It's different depending on what you're talking about. And so to say that patient safety, 86% of nurses reported safety overall, yes, that's true. But there are aspects of care in dialysis units that are unsafe. And that people need to think about that when they're thinking about what patient safety is, and that there can be some aspects that are safe, but there are some aspects that may not be safe. And so I hope we have enough time for 1 question or 2 questions, but we wanted to end up with the importance of knowing and using the evidence that affects your practice. And as nurses, you have a voice, but you will only have a voice if it's informed by evidence. So any questions? I know we're at the end of our time. Okay, thank you.
I just want to thank Dr. Linda Flynn and Dr. Thomas-Hawkins for their presentation.